Hi friends, welcome back to Next Level Ophthalmology. Today we'll be dealing with the second class of orbit, signs and symptoms in orbital diseases, and how would you go on to investigate an orbital disease. So what are the signs and symptoms? Symptoms can be a little non-specific. They can present with orbital pain, diplopia, visual blurring, swelling of the periorbital tissues or protrusion of the eyeball. Whereas proptosis, dystopia and enophthalmos are quite specific signs of an orbital disease. What is proptosis? Proptosis is forward protrusion of the eyeball. Dystopia is displacement of the eyeball. The eyeball may not be protruded. So depending on whether it is displaced upwards, downwards or horizontally, we call it vertical or horizontal dystopia. Enophthalmos is inward positioning of the eyeball. Then the other non-specific signs are ophthalmoplegia, that is loss of movements of the eyeball, which can be partial or complete. Chemosis, it shows that there is increased orbital pressure. Lagophthalmos is inability to close the eyelids because of proptosis. Choroidal folds is due to protrusion of the eyeball from posteriorly causing folds on the choroid, and then optic disc changes like edema and atrophy. So let's begin the class with proptosis. Proptosis is defined as forward displacement of the eyeball beyond the orbital margins. Normally it is around 21 to 25 mm in front of the orbital margins. Any discrepancy of 2 mm between the two eyes is needed to define proptosis clinically, or anything more than 25 mm we call it proptosis. So although the word exophthalmos is commonly used, we usually restrict it to thyroid associated proptosis. So before we label any patient with proptosis, we should know what pseudoproptosis is. So when can an eye falsely look protruded? So if there is unilateral high or bilateral high or pathological myopia, the eye looks elongated and longer and bigger and more prominent. Okay, so this is an important cause for pseudoproptosis. An axial length measurement will guide you to rule out true proptosis. Contralateral enophthalmos. Suppose the other eye has had a blowout fracture long back. Okay, there might be a small enophthalmos in that eye, causing this eye to look more prominent. So this is an important cause for pseudoproptosis. Contralateral hypermetropia. We know that hypermetropes, the eyeball is shorter. Microphthalmos, nanophthalmos, and post radiation. Contralateral ptosis or unilateral lid retraction can also simulate proptosis. So these are the causes of pseudoproptosis. So how do we classify proptosis? Based on presentation, it can be unilateral or bilateral. It can be of sudden onset or gradual onset. It can be constant or variable, or it can be pulsatile. So here is a case of bilateral proptosis. Again another case of bilateral proptosis, and here is a case of unilateral proptosis. So we can, based on the etiology, classify proptosis as congenital, like cysts like dermoid cysts, teratoma, meningoencephaloceles can present with proptosis. Following trauma, there can be orbital hemorrhage, traumatic aneurysms, orbital emphysema, blow-in fractures can also cause proptosis. Inflammatory causes more commonly that we encounter in an outpatient clinic is orbital cellulitis, orbital pseudotumor, abscesses, cavernous sinus thrombosis, infections like sarcoidosis and gamma. Vascular causes include orbital varix, aneurysms, and rarely angioneurotic edema. Neoplasms include benign and malignant and metastatic neoplasms. Then acquired cysts include parasitic cysts, more commonly in our belt here, implantation cysts and mucoceles. In systemic conditions, the proptosis can be bilateral. Most common cause of unilateral and bilateral proptosis is thyroid associated orbitopathy, okay, also known as TAO, also known as Graves ophthalmopathy or thyroid eye disease. So these are the synonyms. Then you can have amyloidosis and histiocytosis rarely. Let's take a question at this point now. Which tumor presents with an increase in the size of proptosis during upper respiratory infections? So there is no logic in this. This is just a knowledge based question. So the answer is lymphangioma. So these tumors are benign and known to increase in size in children during an episode of URTI, and sometimes they may suddenly grow in size and rupture, leading to formation of something known as a chocolate cyst. If a mass is pushing the globe from posteriorly, all of the following are clinical signs except. So from posteriorly, remember the surgical spaces, we are talking about the intraconal space. So there is a mass here that is pushing the globe from posteriorly. So what are the signs that you get? Myopia. Is it true? No, because when you push the globe from behind, there is a anterior-posterior shortening. So this causes hypermetropia and not myopia. So you should get hypermetropia. Macular edema can be present. Axial proptosis can be very well present, and choroidal folds can also be seen. So the right answer here is myopia. There will be hypermetropia when there is a mass pushing the globe from posteriorly. Match the following clinical signs of proptosis with the site of lesion. So suppose there is proptosis with optociliary shunts. Optociliary shunts are small shunt vessels that are seen in the optic disc that are formed between the retinal circulation and the choroidal circulations. The choroidal circulation is present in the peripapillary area, and the retinal circulation arises from the center of the disc. So when these collaterals are formed, it signifies long-standing optic nerve compression. So that the answer for A is intraconal slow-growing tumor. Okay. Proptosis with ophthalmoplegia with corneal anesthesia. We have discussed this. So this is superior orbital fissure syndrome. Proptosis with corneal anesthesia, with ophthalmoplegia, with loss of vision. We localize the lesion to orbital apex. Okay, so the last one is proptosis with corkscrew vessels over the conjunctiva. It's usually seen in cavernous sinus or caroticocavernous fistula. So this is the right answer. So A should be 3. So A is 3 here and here. B is 1. C is 2. So the right answer here is B. Okay. So these are subtle points on examination that will help you to understand what the probable etiology might be. So how do we work up a case of proptosis? Again, we start with the basic history taking. When did it start? How did it start? Has it been progressing? Does it have a variation with time or any part of the day, with any position, with any infection? Was there any history of trauma? It's very important to elicit this history. What are the visual complaints? Do you have loss of vision? Do you have blurring of vision? Do you have diplopia, or do you feel there's a loss of a particular field? Is there any systemic complaint? Have there been any other swellings in the body? Do you have generalized weakness? All these are pertinent depending on what probable etiology you're dealing with. So suppose you're dealing with an acute onset proptosis, consider infectious and traumatic etiology. Okay, when you're dealing with chronic proptosis, think of parasites, chronic inflammatory conditions like tuberculosis, sarcoidosis, systemic conditions, and metabolic causes. When you're thinking of when you're dealing with proptosis in childhood, you have to be cautious of congenital causes. If there is associated visual loss, you have to be a little more cautious and think of intraconal lesions that are compressing the optic nerve. When there is associated ophthalmoplegia, think of lesions at the orbital apex. When the proptosis increases in size during infections, you think about lymphangiomas. So examination, again I would emphasize you do a good general physical examination and a good thorough ophthalmic examination and then a systemic examination. So there are subtle points that you can pick up on clinical examination that might help you hint to a probable diagnosis, like I said. So if there is associated visual impairment, RAPD, color vision disturbances, you think of lesions at the optic nerve. So the lesion probably is in the intracorneal space. Okay, it has been compressing the optic nerve, or it might be at the orbital apex as well. So restricted ocular motility, intracorneal and extracorneal lesions can be there. So depending on the type of proptosis, whether it's axial or eccentric, you can decide whether the lesion is intracorneal or extracorneal. So obviously what is within the cone will cause just forward protrusion of the eyeball. When the lesion is somewhere in the peripheral space, there will be an eccentric proptosis on depending on where the mass is. So when looking at the fundus, if you see disc edema, it shows acute compression. If you see optic atrophy and optic ociliary shunts, it signifies chronic compression. If you see a central retinal artery pulsating, you know that it is a severe acute compression of the optic nerve. Presence of hypermetropia, macular edema, we have discussed this, mass pushing the globe from behind, loss of corneal sensations, think about superior orbital fissure, presence of corkscrew vessels, think of CCF, and if again, if there are presence of field effects, you think of compression of the optic nerve. So to reiterate, general physical examination, a good complete ophthalmic examination, each point in ophthalmic examination is important. Visual acuity, near vision, color vision, look at the pupils, look at the ocular movements, look at the position of the eyeballs, look at a good proptosis examination should follow a ophthalmic examination, and then not to forget fundus examination in a dilated pupil, and then a systemic examination to rule out any systemic associations for the proptosis. All right. So, coming to examination of proptosis per se, like in any surgery case, we do an inspection palpation. There's no percussion, so just move on to auscultation and transillumination. In inspection, rule out pseudoproptosis that we already discussed till now. Ascertain whether the proptosis is unilateral or bilateral. Note any abnormality in the shape of the skull. We have discussed developmental anomalies of the skull and the orbit. Observe whether proptosis is axial or eccentric. So these can be done by doing some measurements that I'll talk about. Next is palpation. It's to know about the compressibility of the tumor. For orbital thrill or any swelling around the eyeball, you have to palpate for the regional lymph nodes, feel the orbital rim to note any thickening or loss of continuity. It is next is auscultation. It's most important in a CCF where you want to hear a brood. Okay. The next is a transillumination test when you want to look for cystic swellings in the anterior orbital part. Okay. If the proptosis is aggravated by certain maneuvers like a head dependent position, valsalva, or jugular compression, you have to think of orbital varices and hemangioma. So these are special tests that you need to perform depending on whether you're dealing with these conditions. Okay. So how do we measure proptosis? We need instruments called exophthalmometers, and the measurement is known as exophthalmometry. Okay. It is done to assess the severity and type of proptosis. So we see two images here. The one on the left is called Hertel's exophthalmometer. It is used to measure eccentric proptosis, and Lewett's exophthalmometer is used to measure axial proptosis. So clinically, proptosis is assessed by standing behind the patient and lifting the head to slightly observe lifting the head slightly to observe both eyes if they are at the same level. So while measuring proptosis, the following measurements were found. Determine the type of proptosis. Okay. So what are the three important measures that you do? So this is the nasal bridge. This is the highest point on the superior orbital rim. the lowest point on the inferior orbital rim. Okay, alright. So, and here is the center of cornea. First, we'll measure the AP measurement using the Lewitt's exophthalmometer. And here they say in the right eye it is 21 mm and left it is 26. So obviously there is left-sided proptosis. So you can easily strike off the fourth option, which says right-sided in ophthalmos, because 21 is still a good number. Okay. So there is obviously left-sided proptosis. Whether it is axial or eccentric, these two columns will help us. So what is the second column about? Measurement from the highest point of the superior orbital rim to the center of pupil. So from this point to this point. Okay. So they say this is 13 mm in both eyes. Okay. So 13 mm, and measurement of the center of the nasal bridge to the center of pupil. Okay. So this measurement they say is 18, and in this eye it is 22. So we know that even though this is same, this is a little more. Okay, so the left eye has got eccentric proptosis. And where do you think the dystopia is? The dystopia is horizontal. So if there is a discrepancy in this vertical value, then we call it vertical dystopia. If there is a discrepancy in this horizontal measurements, we call it horizontal dystopia. So the answer, let's read one by one. Left-sided axial, no. This is an eccentric proptosis, so it can't be A. Left-sided eccentric proptosis, globe displaced vertically, no. We have realized that it is horizontal dystopia. So the answer is C, left-sided eccentric hyperproptosis with globe displaced horizontally. So what is dystopia? Dystopia is displacement of the globe with or without proptosis. That is immaterial, whether the globe is pushed outside the orbital rim or not. So if the globe is pushed anteriorly, inferiorly and medially, okay, suppose this is the nose, the globe is pushed anteriorly, inferiorly and medially, and is associated with an S-shaped ptosis of the upper lid. The most probable cause of such proptosis is. So let's take the orbit as a compartment and divide it into four parts. So the eye is moving towards the inferonasal part. So the lesion should be diagonally opposite to the side of displacement. So if there is an optic nerve tumor, there will be axial proptosis, right? If there is an ethmoidal sinus tumor, so ethmoidal sinus is somewhere here, so the eye will be pushed this way. So this is also wrong. Tumor arising from the maxillary sinus. The maxillary sinus is situated inferiorly. It will push the eyeball up. So this is wrong. Tumor of the lacrimal gland. So the lacrimal gland is situated in the superotemporal aspect of the orbit. So lacrimal glands tumors are associated with inferonasal dystopia. So here is an image of a lady presenting with S-shaped lid ptosis with the eyeball being pushed inferiorly and medially. So if you observe, the reflex of the cornea is still central. This is just the globe is displaced without a change in the ocular alignment. Okay. So depending on the position of the globe, you can think of a probable etiology. So down displacement is frontal region tumors, frontal mucoceles are common causes. Upward displacement, maxillary tumors. Temporal displacement, something from the medial wall, that is ethmoidal mucocele. Coming to enophthalmos, what is enophthalmos? It's inward displacement of the globe. It can be following trauma, which is the most common cause. Usually it follows blowout trauma, blowout fractures of the orbital floor or the medial wall, leading to prolapse of the contents of the orbit into the neighboring structures. So there is a decrease in the contents of the orbit, leading to enophthalmos. The next is post-inflammatory. Usually it follows orbital pseudotumor. After a couple of inflammatory episodes, you can have cicatrization of the ocular muscles and the orbital fat, leading to enophthalmos. Horner syndrome, maxillary hypoplasia, and atrophy of the orbital contents can follow irradiation and cicatrizing metastatic carcinomas. So, trauma and post-inflammatory are the most common causes of enophthalmos. So, how to investigate orbital diseases? We need hematological, more importantly, radiological, and most definitive is by tissue diagnosis. So, let's look at one by one. Hematological are important when you're thinking of systemic conditions, when you're thinking of thyroid, when you're thinking of some hematological malignancies, when you're thinking of sarcoid or syphilis, or when you're thinking of helminthic infestations. Okay, so the blood tests depend on what you are thinking about. So you do not conduct a battery of tests in all cases of proptosis. A clinical examination will hint you towards a probable diagnosis based on which the investigations need to be ordered. Radiological, you can have an X-ray of the orbit, CT scan, MRI, venography, or an orbital echography. You can even use a digital subtraction angiography to look for CCF. Okay, tissue diagnosis depends on whether you have taken a excision of the whole mass or incision and biopsy. So let's look at what X-ray of the orbit. You get a general view about the orbit, orbital cavity, if there is any enlargement of the orbital foramina, if there are major fractures, if there are calcifications and hyperostosis. There are different views in which you can look at the orbital disorders. So in frontal view, it's a general AP view to compare the two orbits. Culpal view is to visualize the superior orbital fissure, and it is performed by keeping the forehead and the nose in close opposition to the vertical meridian. So you get to visualize the superior orbital fissure. Whereas Waters' view is to study the orbital floor fractures, and it's performed by tilting the head backwards uh, so that you can visualize the orbital floor. Ree's view is again to visualize the optic foramen. It is taken in a lying down position with the forehead touching on the horizontal meridian. Then lateral view is to uh, assess the nasopharynx. CT is most common used modality of investigation. It gives more information than X-ray. It gives the exact size and location of the lesion. Also, you get to look at the neighboring structures like the nasopharynx, the paranasal sinuses, anterior cranial fossa, and the rest of the skull also. Magnetic resonance imaging (MRI) is the best to study soft tissue. So, orbital apex or optic nerve, extraocular muscles are best studied using MRI. Okay. Ultrasonography or orbital echography is used to visualize solid and cysts and infiltrative masses. You can even measure the extraocular muscle width using orbital echography. MR venogram is useful in vascular disorders like varix, and carotid angiogram and digital subtraction angiography are useful in evaluating CCF. Okay. Let's take a question at this point. In the axial section of the mid-orbit, a prominent structure is seen crossing from the lateral to the medial side. Okay, can you see this lesion? What structure is this? Optic nerve. Optic nerve travels from the orbital apex towards the globe. Okay, it's sinuous in nature, around 2.5 centimeters in length. So this is not the right answer. Central retinal artery travels within the optic nerve and it's not seen so prominently, so no, this is not the answer. Superior ophthalmic vein. Yes, superior ophthalmic vein is seen in the mid-orbit traveling from lateral part of the orbit towards the medial side. It is formed by conjugation of the central retinal vein and the vortex veins and others, and leading to a very prominent structures. Enlargement of the superior ophthalmic vein is an important radiographic sign and is seen in uh, carotico-cavernous fistulas, cavernous sinus thrombosis, and to name a few. Okay. So the right answer here is superior ophthalmic vein. The frequency of ultrasound used for orbital and ocular imaging. is 5 megahertz, 10 megahertz, 15, 20. So the right answer is 10. You have to remember this number. So remember, ultrasound is something to do with the waves. Okay. So the shorter the wavelength, the lesser is their penetrance. The longer the wavelength, the more they penetrate. So in conditions in which you want a deeper penetration like the abdomen, you have to use longer wavelengths. So when the wavelengths are longer, the frequencies are shorter. Like you see here, deep abdomen you have just 2.5 megahertz. So it's a very long wave. Okay, the wavelength is very long. But when you come to the eye, it's almost 8 to 10 megahertz. So when you do a UBM, ultrasound biomicroscopy, here you are able to see even the ciliary body, ciliary processes, zonules. So this requires very short wavelength because you don't want very deep penetration. The penetration is very less. So here the uh, frequency is around 50 megahertz. So you remember 10 for the eye and the orbit, 50 in UBM. Okay. So general abdominal scan that you do is 2.5 and then gynecological scan is 3.5. You don't want a very deep penetrance. And then breast and thyroid are more superficial structures. So again 7 to 7.5. Musculoskeletal is higher than what you need for the eye. So hope this is clear. Identify the section of the CT scan of the orbit that is shown in this picture. So you should know there are three main sections of scan that you see. So this scan is taken, it is parallel to the left right axis of the body. So this is known as the coronal scan. Okay, so the right answer here is coronal. So what are the three planes? Coronal plane or the coronal scan is the one that is parallel to the left right axis of the body. Axial plane is perpendicular to the cephalocaudal axis of the body. So this is cephalocaudal axis. It's this way. So whatever plane is perpendicular to this is axial plane. So you can see the orbit from below. Okay. Coronal plane is like you're looking at the face, right at the face. And sagittal plane is looking at someone from the side. So this is parallel to the AP or anteroposterior axis of the body. Pick the right statement about MRI of the orbit. So this T1, T2 is very confusing. Let's understand that T1 is to study the normal physiology and normal anatomy. T2 is to study disease states. So whatever contains lot of water will become hyper intense on T2. Okay. So optic nerve, it's an extension of the brain. It is hyper intense in T1 and hypo intense in T2. So because it is an extension of brain, it behaves like gray matter. Okay, so what happens to gray matter in T1 and T2? In T1 it is gray, in T2 it is ulta, it becomes lighter. So it should be hypo in T1 and hyper in T2. So this statement is wrong. Orbital fat is hyperintense on T1 and intermediate on T2. Okay. Lacrimal gland is intermediate in T1 but hyperintense in T2. Extraocular muscles are hyperintense in T1 and T2. So the right answer here is orbital fat, which is hyperintense on T1 and intermediate on T2. So how do we remember all this? Let's look at a chart here. T1 images show the hypointensity of water containing substances like aqueous, vitreous, everything looks hypo or darker. Gray matter appears gray and white matter appears white. In T2, there is hyperintensity of water containing structures like vitreous, CSF, pus, blood, optic nerve sheath. So gray matter appears white and white matter appears gray. So structures like sclera, choroid and retina, they are intermediate on T1 and T2, they become hypointense. Whereas extraocular muscles, lacrimal gland, they remain intermediate throughout the study. What about optic nerve? I told you it is an extension of the gray matter. So intermediate on T1 and hyperintense on T2. Optic nerve sheath is also similar, hypo on T1 and hyper on T2. Orbital fat is always a little bright only. So it is hyper intense on T1 and intermediate on T2. So we need special sequences to suppress the fat to visualize the optic nerve. The most desired imaging modality for orbital apex is obviously it is the MR orbit. So X-ray you will not get so much information. Orbital echography cannot penetrate so deep. CT scan again it gives only the bony part of the orbital apex. So the soft tissue part of it is best appreciated on the MRI scan. What about tissue diagnosis? It gives you the final diagnosis depending on what you should plan your treatment. So it can be done by a fine needle, aspiration biopsy guided by CT or ultrasound, or incision biopsy or excision biopsy. So depending on your histopathological diagnosis, you can establish the cause for the proptosis or orbital disease. So here we end the class for today. Let's meet next week for the third class. Thank you.